Hi, I'm Dr. Larry Eichenfield from the University of California, San Diego, where I'm a professor of dermatology and pediatrics and vice chair of the department. Today, I was asked to talk about topical ruxolitinib and particularly the pediatric trial called the TRuE-AD3 trial and mechanism of action of topical ruxolitinib in relationship to this trial, and also sort of put it in perspective compared to sort of real world experience. So, topical ruxolitinib we've had approved for a few years. It's a highly effective JAK inhibitor. So the mechanism of action is as a topical JAK inhibitor that really inhibits a set of inflammatory cytokines because the JAK inhibitors actually work to sort of block the JAK-STAT signaling, which can be stimulated by a variety of specific cytokines. And so topical JAK inhibition works topically. In the topical ruxolitinib trial in younger children, the same product was used that we've had approved before for both atopic dermatitis and vitiligo, ages 12 years of age and older. So this was a study of 2 to 11-year-olds with mild to moderate atopic dermatitis. And this was a vehicle-controlled study, typical design, 2-to-1 randomization. So the children got topical ruxolitinib at two-thirds of them as compared to about a third with the vehicle. BID application, and patients had a minimum of 3% body surface area up to 20% body surface area. And that's consistent with what was the prior approval and now the approval of topical Rux with its use up to 20% of body involvement. So patients receive the medicine twice a day up to 8 weeks, or the vehicle control cream, and both safety and efficacy were looked at. Consistent with the prior studies in topical ruxolitinib, we had very good efficacy in the study. And I'm going to be really highlighting the 1.5% ruxolitinib cream. The study also had a 0.75% Rux, half the strength, but there was really, I think, less efficacy and no safety advantage because the 1.5% had really good safety data. So subsequently, that's the one that was approved in this age group. The percentage of patients who made it to clear or almost clear and at least a two-step improvement was 56.5%, as compared to less than 11% for the vehicle group. As expected from the mechanism of JAKs, not only was there an anti-inflammatory effect, but an anti-itch effect as well, with about over 40% of the patients at the end of the study having at least a 4-point drop in itch. And of the patients who were of age 60 years plus, where they did the actual itch evaluation. Very importantly, with a topical, we looked at toleration, and the drug was quite well tolerated, with very little evidence of stinging and burning associated with it. So overall, in this group of patients who were studied, and I should point out that the average baseline body surface area, it was 3 to 20% to get into the study, but it was around 10.5 to 11% body surface area. So a significant amount of eczema that did with over 65% of patients having facial involvement, did quite well with this clinical study. Very importantly, from a safety standpoint, there was no evidence suggestive of any systemic JAK inhibition. So serious infections, the adverse cardiovascular events, malignancies, and thromboses, none of those were observed, and there was no accumulation of the medicine with use over time from a PK standpoint. So in clinical practice, I think topical ruxolitinib has very strong efficacy as a non-steroid. It can be very useful on any parts of the body, but especially areas that might need otherwise persistent topical corticosteroid or sensitive skin areas, such as the face. I put this in context of both longer-term safety data. There was a recent evaluation of an integrated safety analysis of 2 to 17-year-olds, including this particular study that was presented at the Quad AI, and it showed essentially that there were like really no signals of JAK inhibition in all of the patients. These were 8 clinical studies that were looked at in the kids. There were only 2 kids who had serious infections, 1 mycoplasma pneumonia and 1 case of eczema hepaticum. So it's certainly nothing out of the ordinary for a population that was being followed for an extended period of time. So I think we have extended safety experience as well as that high efficacy. And we were very happy that the 2 to 11-year-olds got added in to the approval process of this drug because I think it's very helpful in clinical practice.